So as everybody's coming in to have a seat, I'll go ahead and introduce Dr. Sagar Naik. He received his medical degree from Baroda Medical College in India. He completed his residency and fellowship at Methodist Hospital in Brooklyn, New York, and he's board certified in internal medicine and pulmonology. For over 20 years, he's been practicing in the realm of pulmonology, but also specializes in interventional pulmonology. He's been here since just after 2010, and he actually led the first IBIS procedure in the area and does a lot with the robotics-assisted lung biopsies and non-small cell lung cancer. He oversees the Lee Physicians Pulmonology Group and is the medical director for Lee Health Asthma and COPD management programs. Big local cheers. And one of the areas that he specializes in is bronchial thermoplasty, which is one of the first things he introduced when he came into practice here in the west southern part of Florida. So thank you, Dr. Naik, for being here, and the floor is yours.
Thank you, Angela, for that kind introduction. Thank you, everyone, for being here, for inviting me here today. It's an exciting day to be here. Shout out to Wanda and Shelby for helping arrange getting me here. And of course, a huge shout out to my partner in crime, Teresa Sume, with the Asthma COPD Management Program at Lee Health, who has really helped and guided me and has set up such a wonderful program for our folks here in Southwest Florida. So without further ado, I would like to dive into today's topic. It's an interesting topic. I really appreciate picking something that's maybe a little bit off the beaten path, if you will, in terms of our conversations with asthma, and yet so very, very, very important. Asthma in pregnancy. That's what we're going to be talking about today. I'm glad everybody's back from their coffee break, but if it's getting too boring, do let me know and we'll speed things along. All right. Let's see. So I do not have any financial disclosures to report. In today's topic, we'll try to go over, I'm going to skip number one. I thought I'd talk about it, but then I realized that it would be somewhat redundant at an asthma coalition. But I will definitely like to delve into not asthma in pregnancy in terms of what maternal factors can affect the risk of asthma in the child, and how does asthma affect the pregnant mother. So we're going to kind of broaden it out both to the mother and the child. And last but not the least, touching a little bit about how do we treat a asthma patient in pregnancy. And as part of the healthcare field, all of us have relationships with our patients. Sometimes they spend 2 seconds in my office, but they will spend hours of their time interacting with their respiratory therapist, their nurse, their home care nurse, their pharmacist. They will always be asking questions. What do I do about this? What do I do about that? And I thought that this would be a way to kind of get everybody on the same page of where the current thought process is with this. So we know that asthma is an airway disorder. It's chronic, which is long-standing. There's inflammation in the airways that comes and goes. To say it's variable, you can be normal one moment and wheezing the next. There is airflow obstruction, which means that the bronchial tubes taking air in and out of our lungs narrow down, and that manifests as shortness of breath, cough, wheezing, chest tightness. And there's bronchial hyperresponsiveness, which is to say some trigger, maybe it's an allergen, maybe it's a change in weather, can cause our bronchial tubes to narrow down, and some medicines can cause them to open back up again. And this definition is kind of like a marriage between the two major national definitions. One is the NAEPP and one is the GINA guidelines. So I won't dwell on this too much. Like I said, I think we all know this, the airways inflammation part of how asthma works. And as our knowledge of immunoglobulins and monoclonal antibody therapies and interleukins and inflammatory mediators have evolved over the last 2 decades. We're starting to better understand atopic asthma, type 2 asthma, allergy mediated, eosinophil mediated, so on and so forth. And these have therapeutic implications as well. Again, probably somewhat redundant for today's audience. I know you all know this, but asthma is a big deal in terms of patients affected, mortality, ER visits, number of days lost from work, so on and so forth. And so it goes to show that if asthma is such a big problem in the general population, pregnant women are not exempt from getting it. Asthma, this was a slide that I just wanted to put in there to illustrate that it seems a preconceived notion sometimes that asthma is a childhood disorder, and yet when we look at national data, it turns out that adults are affected by asthma just as much. And in my role as a critical care doc who runs, for the most part, the intensive care units in town and does a lot of pulmonology, people ask me, well, you probably don't see any asthma, that's for the pediatricians, right? I'm like, no, a good chunk of them actually are adults and develop it when they move to Florida, believe it or not. It somehow does affect females more. There is some disparity as far as socioeconomic status is concerned, maybe exposure to pollution or availability of meds. It's across the country. A lot of people say, well, in the warm weather, everybody's outdoors, it shouldn't make a difference. But down here in the South, we're not too far behind the Northeast in terms of asthma prevalence. And then when you look at big cities, you would imagine a lot of pollution-mediated asthma, which there is. But then when you look at small towns, we have just as much asthma. So whether you're in a small, medium, or large city, there's plenty of asthma to go around, including asthma in pregnancy. Emergency department visits have not gone down over the last 20 years, although perhaps the mortality is getting better, which is good news. We're all collectively doing something right. We all know what causes asthma. Again, I won't delve too much into the details, but we all know the usual culprits: allergies, family history, immune mechanisms, and of course the big one, smoking. We all know how to diagnose asthma as well. Bronchial hyperreactivity on your standard PFTs, a 12% improvement and 200 ml improvement in your FEV1, although last year they have changed this definition. Or you can do bronchoprovocation testing with methacholine. We, of course, do both throughout the system over here. So with that introduction, let's delve right into our meat and potatoes for today, which is asthma in pregnancy. What I want to start out with is, if you're talking about asthma in pregnancy, we obviously need to talk about how it affects the pregnant mother, but let's begin by looking at some of the things that can affect the child. And this is always a good place to start out with. When you are talking to a pregnant female with asthma, you start talking about the child. That's where you're going to get their attention. That's when you're going to get their buy-in. Surprisingly and counterintuitively, and this is not something that you can necessarily counsel a patient about, life just happens, but believe it or not, the older the mother's age, the lower the risk of asthma. This just bears out in statistics. Nobody knows why. It can be genetically inherited. If the patient says that my dad or mom or cousins or brothers or sisters had asthma, it's a likelihood that she may have asthma also, although we do not have strict genetic patterns behind it. And it's fair to assume that not only the mother is at risk, but the child is at risk also. There have been genes that we have identified. There have been inflammatory mediators that we have been identified. Thymic stromal lymphopoietin is one of the latest ones, and they've already come out with the monoclonal antibody therapy targeting it. We do not traditionally do detailed genetic testing in our asthmatic pregnant patients, but if they're on one of these commercially available DNA test kits and they come to you and say, hey, this popped up, what does it mean? It's not a straight cut inheritance pattern, but yes, if you have one of these genetic issues, you are at risk for asthma. Surprising more stuff, vitamin D deficiency in the mother can cause an increased risk of asthma in the child. Who knew? And who would even think that this is an issue in Florida? But believe it or not, it is, because we're all indoors, where it is 72 degrees and fluorescent 24 hours a day. Nobody's really outside, right? I mean, we are all indoors. So there is vitamin D deficiency in Florida, and believe it or not, you can reduce the risk of asthma in the child by making sure that the mother gets a robust vitamin D supplementation. Would we give it to everybody? No. Would we give it to somebody who is at risk? Yeah, we probably should. There's no formal guidelines, but a lot of expert opinion points towards that. If you have one of these genetic markers or there are other risk factors, ramp up the vitamin D for the mother, reduce the chances of asthma in the child. Then the dietary intake, believe it or not, ties into asthma as well. Who would have thought of that? But our diet, unfortunately, is largely based on omega-6 fatty acids. That's what you get in your bag of Doritos. But the healthier version of it, which is the omega-3 polyunsaturated fatty acids, or PUFAs, have been associated with a reduced risk of asthma as compared to the more unhealthy diet. Something to talk about your pregnant mothers, that, hey, how you eat can affect whether or not your child will suffer from asthma. Higher vitamin E intake, vitamin C supplementation, all of this in the mother has been shown to reduce the chances of the child getting asthma. The vitamin C study was specifically mothers who are pregnant who are still smoking. High dose vitamin C will reduce the chances of their child getting asthma. Sugar consumption, high sugar consumption in the mother is associated with higher risk of asthma in the child. Obesity in the mother is associated with a higher risk of asthma in the mother and in the child. Everybody's allowed some cravings, but if they're hitting the unhealthy pies and cakes too often, that can be a problem. And this is surprising stuff. Like, again, who would have thought that there's any relationship between body weight and asthma? And yet more and more science is emerging about the relationship between obesity and body inflammatory state. And a lot of new drugs are coming down the pipeline. It's all over the news about how we are going to be targeting this going in the future. This slide goes without saying, and yet unfortunately it is very common. Pregnant women who smoke. It is tragic, and yet it happens all the time. And I think it is excruciatingly important that we use pregnancy as our best possible opportunity to convince the patient to quit smoking. Higher risk for the mother and higher risk for the child of developing asthma. This is acetaminophen by the mother could increase asthma rates in the child. I would not suggest that they completely avoid it. If they need it, they obviously need it. But if somebody is hitting it a little too often, that might be somebody that you want to talk down a little bit. Same thing with acid suppressive medicines. So if the mother is suffering from preeclampsia, that is a risk for asthma in the child, believe it or not. Premature delivery is a risk for asthma in the child. Children born by cesarean section, increased risk for asthma in the child. There was a, let's call it a fashionable trend towards C-section deliveries. Maybe not this past decade, but the 2 decades previous to that. You can schedule it. It's under general anesthesia. It's easy, convenient for the obstetrician and for the patient. However, now data is emerging to say that we might have to rethink our strategy of C-section deliveries for all The natural way is probably the better way, and a lot of reasons are emerging why. One of them being C-section deliveries. The child has a higher risk for asthma. How? Why? How can that even be? There was a hygiene hypothesis that was proposed 20 or 30 years ago, which says how much antigenic stimulus you give the child might determine how well their immune system develops and how well they can fight against allergen triggered immune hyperresponsiveness. So in this day and age of Purell everything and Clorox everything, we might have made things a little too sterile, and maybe the old grandma's tale of, oh, the kids just run around in the mud, maybe there was something to that. So as far as deliveries is concerned, the hypothesis is that exposure to normal vaginal flora during birth is one of the first antigenic stimuli that the child is going to get, and that helps build a healthy immune system. This again is probably pretty intuitive. Breastfeeding is associated with lower risk of asthma in the first 2 years of life. Why? A big driver of asthma in the first 2 years for the child is viral infections. And where does a child get immunity against viral infections? There's only two ways. They can get viral infections, or they can cheat a little bit and inherit that immunity from breast milk. Obviously, the cheating method is better, right? Breastfeeding is important. A longer versus shorter duration of breastfeeding is again associated with a reduced risk of asthma. So for all of your pregnant patients, please do encourage them. I don't know what the latest guidelines are, but the rough rule in my mind that stuck in my brain from med school is 1 year. Try to get as close to that 1 year mark as you can. Not for everyone, but that's the ideal goal. So that's how asthma can affect the child. And there are maternal factors that we can counsel our pregnant asthmatic patients with and say, these are the things that you can do to make sure that your child does not get asthma. And I think it's a pretty powerful message because most mothers are going to be very receptive to this information. And they are going to be very motivated to say, well, if it's about my child, I am going to do it. And I think that that's a great opportunity to get them to quit smoking, rearrange dietary habits, so on and so forth. Then we come to probably the main part of this is, what about the pregnant patient herself? How does asthma affect her? How does asthma affect what she's going through? And obviously the answer is yes, it does. Pregnant patients, this is a rough rule of thumb. It was borne out in a case series of maybe 200 or 300 patients a few decades ago, and it's just a nice thing to remember, and I tell all of my patients this. A pregnant female with asthma, known asthma, in 1/3 of these patients, their asthma is going to get better. In 1/3, it's going to stay the same, and in 1/3, it's going to get worse. That's the rough rule of thumb that was borne out maybe 20 years ago in a study. That having been said, there have been many other studies looking at this more recently, and the trend that has emerged, I'm distilling a lot of studies down into like one message here, but the trend that has emerged is how well your asthma was controlled before you got pregnant is going to be a huge driving force as to how well your asthma remains controlled during pregnancy. So ideally, we try to even encourage our patients, don't think about getting pregnant if you have severe persistent asthma, work on getting that controlled first. Asthma exacerbations can happen in patients anywhere from 1 in 5 to 1 in 2, severe exacerbations 1 in 10. So this is a disease that can affect pregnant females as it does the general population. What are the risk factors for an asthma exacerbation in a pregnant patient? Obesity. We kind of touched upon that in terms of the risk for the child getting asthma, but it is a risk for the pregnant mother getting asthma also. First trimester weight gain, history of exacerbations in the prior 12 months. Like I said, the asthma control prior to pregnancy is going to predict the asthma control during pregnancy. Smoking, very obvious, and anxiety, believe it or not. There is an association between anxiety and asthma. I'm not going to get into too much detail about that, but again, it is one of the factors for sure. Asthma exacerbations can happen in pregnancy, and of course, when they do, it's stress to the mother, it's stress to the baby or the fetus, we should say, it's stress to the primary care doc, to the nurse, to the respiratory therapist, to the pulmonologist, to the intensivist, to the future pediatrician, to the OBGYN doc, to the high-risk OBGYN doc. There's a whole village of people who are going to get really worried when you have asthma exacerbation during pregnancy. For reasons that we do not fully understand. Mostly they happen during the second trimester. They can happen in the third trimester for reasons we don't fully understand. They are relatively less common in the 1 month prior to delivery, which, knock on wood, is a good thing. The huge area of opportunity, I think, for us is the early trimester asthma exacerbations, and we'll touch upon that in just a little bit. The first tendency that a pregnant mother has when she finds out that she is pregnant is to absolutely stop taking any medicine that she was taking before. It is a universal phenomenon. They take all of their stuff and they throw it in the garbage. And that includes the asthma inhalers. And unfortunately, that's why we have these first trimester. You're taking an inhaled steroid, you stop taking it, 2 weeks later, bam, asthma is back. And so we'll talk about that in therapeutics, but that's a huge opportunity for us to say, hey, stick with the program. Don't give up on your asthma treatment. Asthma during pregnancy is associated with maybe a 1 in 5 risk of many bad things. This is, of course, also an amalgamation of many different studies that I've distilled down into one slide. I have put references at the bottom, or at least the most recent ones, but perinatal mortality is understandably worse. Higher rates of spontaneous abortion, uterine hemorrhage, preeclampsia, neonatal mortality, premature infants, low birth weight infants. The risk of all of this is higher in a patient who has asthma during pregnancy. Why? Our best guess is oxygen levels. If you have asthma, you're not breathing well. If you don't have good oxygen levels, everything is suffering. The uterus, the placenta, the neonate, all of it. So during pregnancy, there are some changes to our spirometry parameters, but believe it or not, your large airway metrics, FEV1, FVC, everything roughly stays the same, or maybe slightly gets better. Lung capacity obviously slightly reduced because there's a big gravid uterus preventing a deep inhalation, but everything else actually slightly gets better. PO2 levels are slightly better. PCO2 levels on an ABG are slightly lower than normal. So there's a slight degree of respiratory alkalosis going on. Why is this important? For those of us who are working on the inpatient side of things, in the intensive care unit or in the ER or the hospital wards, if you see a pregnant female with an asthma exacerbation and a PCO2 of 40, that is already too high. That is respiratory acidosis for them. Pseudo-normalization, a normal value that creates the illusion that everything is fine. In normal pregnant asthmatic, it should somewhat be lower than 40. Same with PO2. Their PO2 is much higher in pregnancy. And so if you have a PO2 of 70, that's already too low. How do we diagnose asthma in pregnancy? The same spirometry that we do in non-pregnant patients. You can still do it in pregnancy also. You can check your bronchodilator responsiveness. Obviously, you can look at your clinical features. The one thing that we do not do is the bronchoprovocation testing. It's probably just bad press to have somebody get into a severe asthma attack with methacholine while they are pregnant. So that's one of the relative contraindications. Treatment. So treatment of asthma in pregnancy. These are the four broad categories or pillars of asthma treatment. We talk about how to educate the patient to monitor their symptoms, how they understand what their triggers are and what they can do to control their triggers, education about what asthma is, all the things that we just talked about in terms of risk factors for the mother and the child, and then obviously the most important and hair-raising one, what drugs do you use? So we'll go over all of that briefly. I think we just heard an excellent lecture on how do you monitor asthma symptoms and how do you predict the rate of exacerbations. Dr. Ramirez just gave an excellent talk on that. There is the old asthma control test as well. There is the good old peak expiratory flow monitoring with your green, yellow, red zones, and educating patients on how to kind of track their progress. This stuff works in pregnancy also. It should be done. It should be encouraged. This is how we would treat a non-pregnant asthmatic. This is how we should also monitor a pregnant asthmatic. Control of triggers. If we know that they're allergic to something, that allergen should be avoided. Simple, intuitive, and yet in real life, I have met very few people who are willing to put their hyperallergenic dog on eBay. They will not give up their pets. They will not give up their pets. It's just not going to happen. But they can maybe give up the smoking. Maybe that's an opportunity for us to make a difference, right? They might buy a HEPA filter, $100 at the local big box store, string a few of those up in the home, and maybe you can get some lint and dander and pollen out of the air. There are ways around it, so to speak, but it's obviously important. And then, of course, in select patients, so there's data to show that pregnant women who are smoking, give them vitamin C at a higher dose that might reduce asthma in the child. Vitamin B supplements, we talked about that. Healthy diet, avoidance of excess sugars, we talked about that. Patient education is very, very important. I think all of us here in this room are involved in that in some or the other fashion. Again, a huge shout out to Teresa Sume, who runs our asthma and COPD management program at Lee Health. But everybody should be doing their best to educate patients. The more they know, the better they will be. This is a universal statement for all chronic diseases, whether it's heart disease or hypertension or diabetes or asthma. The more your patient knows, the better they will be at monitoring their symptoms, avoiding triggers, taking the medicines, and staying healthy out of the hospital. Education on inhaler techniques, disease process, coordination with the multidisciplinary care team, all of this is obviously very intuitive, and yet I must mention again, it should happen. This is probably the most important slide as far as asthma treatment is concerned. There is a considerable amount of nuance to it, which I've edited out and I've distilled it down to a single sentence. How you treat asthma in a pregnant female should not be very different than how you treat asthma in a non-pregnant patient. Why? If you cannot breathe, nothing else matters. Your door to needle time for a heart catheterization is 90 minutes. Your door to TPA time for an acute stroke is 3 hours. Your asthma to death time without oxygen, 2 minutes, 3 minutes tops. This is not something that we can fool around. This is worse than heart attack. This is worse than stroke. And so the treatment strategy that we employ is all guns blazing. Do what you have to do. There are no rules. Everything is fair in war. You unleash whatever treatment you can to make the asthma get better controlled, because that baby is suffering without oxygen. That mother is suffering without oxygen. So the GINA guidelines have this stepwise asthma approach that we have all seen and heard about. And roughly this same stepwise approach can be copy-pasted onto any asthmatic pregnant patient. They all should have their short-acting beta agonist inhaler like albuterol, and then based on what their asthma severity is or how often they're using their asthma controller, they should then be stepped up to inhaled steroids, long-acting beta agonists. In more severe asthma, you can add on your long-acting muscarinic agents. And then in very, very severe, we will talk a little bit about what's out there in terms of biologicals. Roughly, I would take home from this slide, it's the same slide whether you're pregnant or not. The same treatment strategy. All patients should have a short-acting beta agonist. That's your albuterol. Your inhaled corticosteroids do reduce asthma exacerbations in pregnancy, okay? And they should be on them. If they're anything other than a mild intermittent, they should be on an inhaled corticosteroid. There are not going to be any randomized control trials of any drugs in asthma just because of it's just not feasible or it's never going to get past the ethics committee. It's just never going to happen. So all of our data on how safe the medicine is during pregnancy is largely retrospective and yet reassuring. If 500 patients have had it and it's been okay, that's something we can take forward to our next patient. So budesonide, as far as inhaled steroids is concerned, has the most amount of retrospective data with it, and no harm to the baby or mother. Fluticasone and beclomethasone also have maybe not as much data as budesonide, but whatever data is out there is very reassuring. So you will, I'm not going to go into the brand names of all of these things, but these are the pharmacological names, if you will, and they are well studied retrospectively without appreciable harm. Salmeterol, as far as long-acting beta agonist is concerned, so now we're talking 12-hour or 24-hour long-term formulations of our short-acting albuterol. Salmeterol has the most amount of retrospective data. Again, nobody's saying that we've done a randomized double-blinded control study in asthmatics. Not going to happen. But looking retrospectively, there is a good amount of data that salmeterol should be fine. Long-acting beta agonists should not be used as monotherapy in asthma. We do not understand why, but there was an asthma trial looking at this in non-pregnant patients, and we don't know why, but just using a long-acting beta agonist without an inhaled steroid caused increased mortality in asthma. And therefore, same as in non-pregnant patients, also in pregnant patients, it should always be either inhaled steroid or inhaled steroid plus long-acting beta agonist. Tiotropium, this is now you're up to step 4, I guess, or you're looking at your more severe persistent cases. They do recommend long-acting muscarinic agents. In non-pregnant patients, the only one to officially have this indication is tiotropium. Again, I'm not using the brand names, but this also then carries forward to pregnant patients. It has been studied retrospectively. Severe persistent asthma in pregnancy beyond long-acting beta agonist, beyond inhaled steroid, they can and should also be on a long-acting muscarinic agent. In the last 3-4 years or so, a bunch of other players have joined the commercial market. I won't go into the brand names again, but aclidinium, glycopyrrolate, umeclidinium have all come out. These are part of various combo inhalers now that they're selling. Because they are newer inhalers, there is no data. That's not to say that they're not okay. It probably will be, hopefully, maybe, knock on wood. But because they're so new, we just don't have enough retrospective evidence. Montelukast can be used in pregnancy. Again, data is very reassuring. Most people are now using Montelukast over Zafirlukast. And so you should continue that. Most asthmatics will probably already be on that even before their pregnancy, and they can safely continue it. Asthma immunotherapy, also colloquially referred to as allergy shots. This is traditionally given by allergy immunology specialists. I would not necessarily recommend starting a pregnant asthmatic on this. but if they were taking it before getting pregnant, and if this was one of the main things standing between them and their next exacerbation, it probably should be continued and probably can safely be continued during pregnancy. And then, of course, systemic steroids. So again, there's going to be a lot of angst or anxiety that, hey, I don't want to use steroids, I'm pregnant, this is going to mess me up. And yet I think our message to pregnant patients is control your asthma. And if steroids is what it takes, then use them. Are there side effects to using steroids in asthma? Yes, there are. Slightly increased risk of malformations like cleft palate, slightly increased risk of preeclampsia. Gestational diabetes is obviously a steroid effect. Anybody who's not diabetic will get diabetic on steroids. That is a guarantee. Low birth weight, neonatal adrenal insufficiency, because the neonate is going to go from bathing in prednisone to all of a sudden not on any prednisone. So they can have acute relative adrenocortical insufficiency at birth. So there are side effects to it, and yet overwhelmingly, if your patient has an asthma exacerbation or wheezing, use steroids. Oral, intravenous, do whatever you got to do. The risk is not nearly as big as the benefit. Then the most recent trend in asthma treatment is the biological agents. There are 5 or 6 agents now targeting various interleukins and inflammatory markers in the asthma pathway. All of these drugs are relatively new. The first one came out maybe 15 years ago, and the rest of them in the last 10 years or so. And therefore, data is limited. The longest available one on the market also therefore happens to have the best available data. It is not a randomized, forward-looking, randomized control trial, but retrospectively, omalizumab does have decent data as far as continuing it in somebody who was already on. I'm not entirely sure whether we would start in pregnancy. I think that would be on a case-by-case basis. Yes, if I had a severe enough asthmatic, I probably would, but you would definitely continue it. There is human data, a retrospective on about maybe 200, 250 patients. I put the link down there. They looked at continuing it, and there was no adverse outcome for the mother or child. All the other newer ones, so there's mepolizumab, reslizumab, there's dupilizumab, there is this one, tezepelizumab. I can't even pronounce half of these things. They're tongue twisters, all of them. These are all newer agents, and therefore we do not have much data on them. Are they safe or not? We don't know. There will never be any randomized controlled trial. We just have to accumulate more time and experience with them. And then on a case-by-case basis, if it's a severe asthmatic and one of these drugs is the only thing keeping them going, take our chances, work with the pharmacist, work with the company, maybe report the data in. Therefore, these companies can build their own set of data from across the country as to how safe the experience turned out to be. I did briefly talk about tezepelumab, the one all the way at the bottom, which links to a gene that they recently discovered that you can use to block one of the big asthma pathways. So that's one of the newest drugs on the market and therefore has the least data. So treatment is the same. That is the moral of the story. Treatment is the same. This is looking at treatment for asthma exacerbation, now coming to the ER, coming to my ICU, coming to the hospital. Everything that we would do is the same. Hit them with neb treatments, hit them with systemic steroids. We use intravenous magnesium sulfate, which has been used safely in pregnancy to treat eclampsia and such. It also has some bronchodilator properties. We use it in asthma exacerbations also. You can do subcutaneous terbutaline, probably not a popular choice, but again, it is a medicine used in pregnancy and therefore can be used for asthma exacerbations. I think I have 1 minute left. Thank you. Any questions? Very good. Well, thank you again for having me here. This was fun, and I hope everybody took home a little something from today's talk.
Dr. Naik, that was fantastic. Thank you so much. Did folks have a question in the audience? It sounds like somebody's trying to speak.
Thank you.